Hi, this is Brian Kim. I'd like to share with you an interesting case referred to me by my partner. This patient is a 46-year-old gentleman who presented with severe glaucoma. It was thought to be angle closure based on the history. However, upon examination, the patient was found to have anterior dislocation of the crystalline lens with pupillary block and incarceration of the lens within the pupil. My partner was able to push the lens back in the posterior segment and then gave the patient pilocarpine to keep it there. So this eye had significant corneal edema, was still recovering. So I decided to operate on the other eye, knowing very well this was going to be a pretty challenging case. So I go ahead and mark the cornea and make my corneal stab incisions, and I'm noticing that there's significant phacodenesis even with doing this maneuver. I'm putting some intracameral lidocaine, and again, you can see the lens wobbling quite a bit. When I'm putting the viscoelastic in the anterior chamber, I can feel that the lens was prolapsing into the anterior chamber. There was not much anterior chamber until I filled the eye with viscoelastic. And I'm going to go ahead and make my triplanar corneal incision, making a vertical groove, and then tunneling within the groove before entering into the anterior chamber. I go ahead and do a puncture capsulorhexis. I was surprised I was able to get through. Usually with the lens being unstable, you have to use a cystotome, but I was able to get through here. You want to be real gentle and make sure that this doesn't radialize. You want to have a good amount of anterior capsular support in case you want to use a capsular tension segment or a capsular tension ring. If the anterior capsular rim is not robust, it can make it difficult to do these maneuvers. So as you can see, as I'm pulling my rhexis fairly slowly, it's causing a little bit of zonular traction, not too bad. And you want to just continue with frequent regrabs and keep pulling and just gently make sure it comes along without causing too much traction. Alternatively, you could put some capsule retractors as you make your rhexis, but thankfully in this case, it was pretty uneventful. The only tricky part for hydrodissection was getting that cannula underneath the anterior capsular edge without causing the lens to wobble too much. But once I got it in there, I was able to get a nice wave. You can see I'm gently trying to decompress the bag on each side. Obviously, this is causing some zonular traction in doing this, but you have to be able to decompress the bag in order to be able to even mobilize the lens at all. So I'm going to go ahead and begin phaco. Immediately you could see as I'm using the fluidics, the lens is really bouncing around, and that's because of the vacuum. And so I'm going to try to use mechanical fracturing forces. I'm going to initiate the double chop maneuver and gently crush this lens and divide it into two pieces. I'm trying to help use my chopper to kind of stabilize the bag as I do these maneuvers. This is the cross chop maneuver. And so again, I'm hoping that I've created three separate pieces, but again, because the bag is going to be somewhat stuck to the lens, and because the bag is unstable, you can see I'm pushing the chopper out a little bit in order to cause a little bit of separation between the bag and the lens as I emulsify these pieces. Regardless if you're using mechanical forces or vacuum to grab the pieces, you're going to have some difficulty because the bag is so unstable. So you can see here I'm grabbing the lens pieces with some vacuum, using the chopper to kind of push the bag out so I don't cause the bag to come into the port. I'm gently trying to use, again, the chopper to kind of push the lens, but you see as I do that, you can see the whole bag is wobbling and moving towards me. So I'm going to have to try to come up with another plan. I come out and then put some viscoelastic into the anterior chamber to stabilize it. And so I decided to try to use some capsule retractors. I'm going to making some stab incisions. You can see I'm stabbing, but then I'm widening as I go because these capsule retractors are a little bit larger. So I believe these capsule retractors are from FCI. They're the reusable type. And the good and the bad is if they're reusable, you can keep using them. However, these were extremely rigid, and I was having a lot of time getting it into the incision. Not only that, once I got it into the incision, the angle was such that it was kind of trying to twist anteriorly and wasn't able to hold the capsule very well. So I decided to take them out, and I went with some iris hooks, knowing very well that I wouldn't get good, deep capsular fornic support. But again, these reusable capsule retractors just didn't seem like they'd be good enough. So now I have my iris hooks in. I'm going to have just a little bit of capsular bag support. It's going to be still quite a challenge to get this lens out. You can see in front of me, the iris hooks are trying to hold the bag, but there's still a little movement to the bag. Trying to use my chopper to keep that in place. You see, I'm trying to really figure out how to get this piece out. If I go with vacuum, it's going to potentially grab the bag. So then I go ahead and just sandwich the lens pieces with the chopper and phaco tip. This frees up this one little fragment, and I'm able to emulsify that. I noticed some of the iris hooks weren't really doing anything, and so I went ahead and took them out and then went back into the eye and began trying to remove these remaining lens pieces. Again, trying to use mechanical forces is helpful. I'm just gently trying to pull the lens towards me and to help emulsify it. However, you can see the bag is, again, really unstable and moving with the lens. And so I'm just gently trying to emulsify each piece as it comes. I'm using the chopper to help kind of stabilize the bag whenever I can. Invariably, in this type of situation, as you try to grab lens pieces with vacuum, you're going to grab the capsular bag. And so as you can see there, I grabbed the bag, but then I was able to stop immediately and then use the chopper to kind of push the lens out of the port and then try again. I have significant epinuclear material still stuck to the capsular bag. And I'm trying to use the chopper and phaco tip to gently maneuver and tease the epinuclear material off the bag. I'm able to do this somewhat successfully. Again, there are moments where the bag also wants to come into the port, and I just try to push that back as I go. And again, I'm just gently taking my time, and I think I got pretty lucky. I was able to grab a little of that epinucleus without grabbing the bag, but then, I go ahead and grab the bag here. I'll let go, reflux and release, and use the chopper to push the bag out of the port, and then eat up the rest of that epinuclear material. Again, you can see the bag just wants to come forward. Thankfully, despite all of this manipulation, I haven't lost any lens material. I'm pretty confident the entire endonucleus has been removed. I haven't lost anything into the vitreous space. And again, slowly the epinuclear material is being removed and trying to keep the capsular bag in place. So eventually I was able to remove all the endonucleus and the epinucleus and left this bag. This bag is completely worthless. Honestly, I can't even imagine how this lens could be salvageable because it had 360 degrees of complete loss. And so the decision was made to go ahead and perform a Yamane technique and go ahead and do a vitrectomy. I'm going ahead and filling the eye with viscoelastic. I went ahead and removed all the iris hooks. So I go ahead and make my marks. I like to mark 2.5 millimeters posterior to the limbus. By doing so, this minimizes UGG syndrome and potential rubbing of the IOL to the iris. But also, if you do this, you're going to have a refractive change. And so when I go 2.5 millimeters back, I also target a -1 for my IOL calculation, and this seems to give me a better, more consistent refractive result. And indented for my trocar about 3.5 millimeters back, and then tunneled, and then went into the eye and put in my AC maintainer, which is a 23 gauge Lewicki, and then went ahead and proceed with the vitrectomy. I have the settings set on IA cut in order to remove the capsular bag very carefully and gently. It's my opinion and experience that in these cases where there's severe lens dislocation or zonular weakness, that there is some underlying abnormalities in the vitreous, and there's very little vitreous support. As a result, less vitreous traction. And so even though you're going to have to want to do a thorough anterior vitrectomy, there's not much vitreous relative to a situation where you have vitreous loss in a standard cataract surgery where you have significant gelatinous vitreous prolapse. I think in these cases, I just don't tend to see that kind of vitreous in this setting. And so after you clean up the capsular bag, you want to do nonetheless a thorough anterior vitrectomy in the eye cut A setting where you're really having a high cut rate, removing as much vitreous as possible. So now I'm going to begin the trailing haptic first technique for the Yamane. Make a contralateral stab incision. I'm getting my needles bent in order to maximize bevel control for the haptic to go into the lumen of the needle. My assistant is helping me advance the IOL, and I'm going to use micrograspers to retrieve the leading haptic through a contralateral incision and pulling it out of that incision. You can see now the leading haptics out of the eye, and this modification facilitates trailing haptic fixation, which is usually the most difficult step of the procedure. I like to place the trailing haptic within the main incision in a U-shaped configuration. This allows for an easier grab-and-go technique of grasping the haptic and then internalizing it into the lumen of the needle. I'm injecting viscoelastic to protect the corneal endothelium, and then with the right needle, I'm tunneling 2 millimeters and then piercing into the vitreous space. U-shaped configuration of the haptic within the wound allows easier grasping of the haptics in order to be able to thread it into the lumen of the right needle. The bevel facing the curve of the haptic allows for easiest fixation of the haptic through the needle. A hemostat is used to disengage the syringe from the needle. Micrograspers are used to internalize the leading haptic, and then the left needle is used to tunnel 2 millimeters through the sclera and then piercing through the vitreous space into the eye. The micrograsper is then used to grasp the leading haptic. The bevel needs to face the curve of the haptic for a maximal fixation and docking platform, and so this is what occurs. And then the needle is pulled out, but as it is pulled, McPherson forceps are used to gently internalize more of the haptic so the entire haptic doesn't get pulled out, and just a little bit of haptic is exposed, and then the tip is then cauterized to create a small bulb. A similar procedure is performed on the other side. As the needle is being pulled out, McPherson forceps is used to secure the haptic and gently thread more of the haptic into the eye. You can see the haptics are then being pushed with the bulb flush to the sclera, and then the conjunctiva reapproximated. The lens is well centered and in good position. I like to place a tendon suture through the main incision in these complicated cases to ensure no vitreous prolapse. I like to make sure that everything's clean and go back and do a little bit more vitrectomy. I'm going to go ahead and inject a little bit of Myochol into the eye to constrict the pupil. I'm going to go ahead and perform my vitrector peripheral iridectomy on these modified settings, which allows for a very slow cut rate and maximal aspiration and vacuum in order to create a very small and controlled size peripheral iridectomy. So at the end, I'm pulling out my Lewicki AC maintainer and my trocar, massaging the sclera, and then painting the surface of the eye to make sure the wounds are sealed. This is another pearl. I would inject subconjunctival ANSEF, and it would cause significant pain despite a block. And so I've been injecting a little bit of lidocaine first, and then injecting the subconjunctival ANSEF. And this seems to help significantly with control of pain. So preoperatively, this patient had a -16 refractive error, largely, in my opinion, due to his anterior dislocation displacement of a crystalline lens. After surgery, he ended up 20/25 uncorrected with a manifest refraction of a -0.5 plus a half, correcting to 20/20. And so again, I like to place the haptics 2.5 millimeters posterior to the limbus, and I target a -1 target for the intraocular lens power calculation, and this seemed to help me get the best refractive result. So despite the challenges of this case, by doing very careful, methodical surgery, I was able to remove the lens in its entirety and then remove this very bad and unstable bag and then perform the Yamane technique. In retrospect, I could have used, again, maybe different or better capsule retractors to help me with the surgery. But again, I'm not sure that the bag would have still been salvageable. The other thing I could have done was to go on really, really low flow settings. During halfway through the phaco, I did reduce my phaco settings with a lower vacuum, lower aspiration flow rate, and I brought the bottle height down a little bit. And so that would have been another thing I could have done differently. But nonetheless, despite not implementing some of these things early on, I was able to get away with it and be able to perform this surgery. It's definitely better to be lucky and good instead of just being either or. And so thankfully things went well and the patient had an excellent refractive outcome. I hope this was helpful to you, and thank you for your attention.